Welcome everyone to this presentation on the prevention of hospital-acquired delirium and the role of the nurse leader in quality healthcare. My name is Patricia Day, and this presentation is going to take us on a journey on how we can identify and hopefully reduce hospital-acquired delirium at the New York Presbyterian Lawrence Hospital campus. So let's get started. Let's begin the journey. Reducing hospital-acquired delirium is a goal that we have here at New York Presbyterian Lawrence Hospital. This four-point system, identifying patients at risk, defining the goal of quality, safety, and value, uniting our system, and creating the potential for positive change, can help us reduce the incidence of hospital-acquired delirium in our elderly patients. Implementing a plan and initiatives that will identify those patients at risk can help improve our overall standard of care and eventually decrease length of stay and improve our patient outcomes. With an occurrence rate of 14 to 56% in our elderly patients, hospital-acquired delirium is an issue that we need to address here at New York Presbyterian Lawrence Hospital. Protecting our patients and their safety should be our number one goal. Often presenting with vague symptoms at first, delirium by nature is a difficult syndrome to identify. Our failure to address patients at risk at the time of admission can create a cascade of negative circumstances that can eventually lead to irreversible cognitive impairments for the patients in our care. Aside from this devastating physical impact on the patients, the prevalence of delirium is a costly one to our organization, both in terms of length of stay and its subsequent economic impact on the hospital and the community. This preventable harm that creates acute changes in our patients and in the lives of the families who love and care for them has an associated cost of $4 to $16 billion annually. If left undetected and untreated, this defined quality issue has the potential to create a long-term adverse event on our community and on the financial status of our organization. Therefore, we, as a collective nursing body, must focus our attention on preventing this devastating health event. In addition, agencies throughout our country have worked on zero harm initiatives for our elderly patients. The Joint Commission and the United States Department of Veterans Affairs are just two that have come up with innovative ideas in how to address hospital-acquired delirium. So now that we as nurses understand why this is an important quality issue for the patients we care for and for our organization, we have to unite the why with the how. How do we as nurses decrease the incidence of hospital-acquired delirium in our patients? Implementing initiatives and interventions that are evidence-based and innovative in nature can carry us on our journey and advance us towards our goal of eliminating this preventable and costly syndrome. As nurses, we're used to implementing strategies that will prevent negative outcomes and improve our practice. Implementing an evidence-based tool can help us identify risk factors in our elderly population and help us answer the question of how. How do we reduce hospital-acquired delirium? How do we improve our process and our clinical outcomes? These four vital steps may be the answer we need. Improving our awareness of the incidence of hospital-acquired delirium is something we need to work on. In addition, we need to improve our ability to screen. Implementing those screening tools will help us identify patients at risk and advance and improve our delivery of care, uniting us in our efforts to change our practice. A worthwhile initiative, the implementation of these initiatives can create a positive effect on our population, improving our own clinical practice by effectively communicating and collaborating across our interdisciplinary teams can lead us to the outcomes that we desire, such as reducing the long-term suffering of the patients we care for and reducing mortality. So now that we recognize the common occurrence of hospital-acquired delirium in our older adult population, we as nurses need to look for guidelines and tools that we can use that will help us identify those patients at risk. The predictive delirium model assesses a patient's baseline vulnerability on admission. It is one tool that serves as a framework for the assessment and intervention for a patient at risk. Assisting the nurse and the team in identifying the risk patient population can help us create a patient-centered plan of care that will prevent or manage those symptoms. Establishing a timeline and identifying the precipitating factors can help us initiate an effective intervention plan, which may include referrals to psychiatry or social work. These actions have the potential to reduce further risk and improve our patients' outcomes. In addition to the predictive delivery model, other instruments and assessment tools, such as the 3D CAM, the confusion assessment method, and the risk model for delirium, are innovative instruments that we can evaluate in our initiative and plan for decreasing and creating a process that addresses the incidence of hospital-acquired delirium. Adopting intervention strategies and evidence-based practice tools that target the identification of risk factors and behaviors in our patient can help us eliminate unnecessary medication uses and costly one-to-one sitters. Adopting this delirium guideline in our facility will unite us as nurses in a standardized approach in reducing and possibly eliminating hospital-acquired delirium. So while the evidence for delirium prevention has been incorporated into certain national guidelines, the direct patient care that we provide lacks the incorporation of an assessment tool that will help us prioritize and identify those patients who may present with risk. Incorporating a delirium prevention nursing practice tool and program at New York Presbyterian Lawrence Hospital will help us increase our knowledge and address any negative attitudes that may prevent the improvement of our practice. Developing and utilizing this implementation plan can work towards embracing the safety that places our patient at the center of care. Reshaping our practices to include a reduction in the pharmacological use of medications can help us move towards the goal of creating change here at New York Presbyterian Lawrence Hospital. Implementing adequate resources such as the guidance of nursing leadership, we can unite and make this possibility a reality. So now that we recognize that non-pharmacological interventions are the most effective means of preventing delirium in our older hospitalized patients, we can focus on three simple things: knowing the facts, understanding the meaning of the experiences, and doing those practice-based techniques that focus our care at the bedside. Creating a culture of engaged learning that incorporates the three-element program that I just identified can successfully increase our awareness and reduce the adverse patient outcomes that are caused by hospital-acquired delirium. These actions can advance our collective practice and improve the quality of care that we deliver to our patients. Utilizing online module learning and simulations, we can decrease the risk of failure in the creation and implementation of our delirium prevention program. Sharing current research and encouraging informal social learning amongst our staff, we can advance the success of this program. Monitoring our improvement by holding quarterly chart audits and monthly staff delirium safety sessions, we will be able to evaluate the increase or decrease in falls, seroquel orders, and the use of costly one-to-one sitters. This inclusive patient-centered safety program is based on the vision and mission of our organization, the ethical and culturally sensitive delivery of care that we as nurses practice every day. As you read the words of Jeremiah 29:11 and Galatians 6:2, we are reminded of Standard 13 and Standard 14 of the scope and standards of practice of the nursing administrator. Implementing current evidence-based nursing knowledge and research in our practice, we can create a climate that promotes quality. Servicing our patients in a safe, effective, efficient, timely, and equitable manner, we arrive at the mission that Christ has given all nurse leaders. We have a responsibility to our collective body to practice in a way that eliminates risk and harm. Gaining strength from God, His hope will be translated to a future in which the occurrence of hospital-acquired delirium in the communities we serve will be reduced and hopefully eliminated. Thank you so much for this opportunity and for going on this journey with me.